Shyam, if I can ask you to take a seat. We have done exceptionally well on our timekeeping despite the reshuffling, and thank you very much to Michelle. Mr. Pasha, can you join me back on stage, please? I'm going to open up the floor. Rakesh, if you can take a couple of the microphones, please. We've got till 10:20 because one of my instructions to my board, it's not often I get to give instructions to my board, was timekeeping. Then I got allocated this position from Makgolokgolo. So I'm going to ask questions. We've got Michelle from IQVIA. We've got Mr. Pasha representing ICPA and Pharmacy Council. And we've got Shyam, obviously, our chairperson. So any questions? There is a roving mic. So I think what I would like to do is just quickly to kick it off. Shyam, could you give me your insight into pharmacist-initiated management of ART?
So I think we've kind of relegated ourselves to medicine supply. And I think there's a huge opportunities because if you look at the initiators of therapy at the moment in South Africa, it's really the nurses that are doing 80% of those prescriptions. They're writing up it. And if you look at the program they go to, which is the NEMAT, is it a 5 to 10 day program?
Yes.
that they go through. So what we've done, we've put together, is it a 5 day? 5 day program. So what we've done, together with the Clinician Society, we sat in a few workshops already. It's going on for about 6 months. And what we did is we put together a strategy to say, how could we then take this to pharmacy? And we're calling it PMAT. So it's very much the 5 day program that the nurses have gone through. We're putting a program that pharmacists will come into. And funding has come through, and Jackie will talk about that later, to try and upskill pharmacists. So what I'm asking you to do is to make sure that you are ready to do it yourself, get your pharmacists involved, and get the training done. Because I think using that, we could escalate the issue of the 19-90-90. The country is struggling with that. We've got 2 million patients to get back onto therapy. They are out there, they need to be brought into the system. So that's the one opportunity we have. The second one is the issue of, like the way we do the morning after pill, we are doing about 100,000 morning after pill in community pharmacy. Did you know that in the country?
A month.
A month. 100,000 a month. So that is a touch point. Every time a patient walks in to access that service, we have an opportunity to convert, to provide maybe the once-off pill that we are using now in terms of prevention, or to look at PEP and offer that kind of service. But think about the opportunity for pharmacy. So please be ready for this one. When we put it out, we've gone and we've committed you guys. We've brought in $1 million from the US to fund this project. We really require you to take this message back to your branches and to your communities that we have a serious opportunity here to make a difference to this country, a huge difference.
Thank you, Shyam. Mr. Pasha, as Pharmacy Council, we are acutely aware of the closed DSP issue, and we also know that patient care is very often compromised in favor of service level agreements between schemes and DSPs. And we've got complicated patients where there's a sole DSP that is a courier pharmacy having to get their medicine from the post office, or from a driver of a truck. Diabetic patients who need to change prescriptions and have to wait 7 days because that's the service level agreement, because we know courier pharmacy cannot deliver same day. What is Pharmacy Council going to try and help assist on this matter?
Thank you very much.
Sorry, I'm putting you on the spot.
Yeah, you are. And I wanted to refer the question to my chair of practice so that she can advise me how to answer it. But then again, I think it is important to realize that earlier on I spoke about deprofessionalization of our profession. I think one of the narratives that we need to bring into fore, particularly as Pharmacy Council, is to move away from what our profession has been made to be. Because we are a profession more than what and how we deliver the profession. So you find that the delivery of the profession is a problem that we are having currently. And that is one of the elements of deprofessionalization, where we become now and are looked at as a way of providing a service. Therefore, it becomes retail. It actually move away from community into the word retail. Hence, I personally, as a community pharmacist, don't like the word retail pharmacy because I am a community pharmacist. I provide a service as a profession. So now, I think the look that we are having right now as a new cancer that comes in, that is what we are looking at, to move away from this possible deprofessionalization that comes with the methods that we have just described. So, and I believe that in the next 4 years, we should be able to achieve some work in that.
Thank you, Mr. Pasha. And I think the critical thing here, guys, is that delivery of medicine to patient is not a service delivery problem. It is not a supply chain. Medicine from the dispensing point to the patient is not just about supply chain. Getting medicines to patients is not enough. The best medicine in the world, the most expensive medicine in the world, if it is not taken properly, is wasted. And so I think as pharmacists, we need that engagement with the patients. And exactly what Mr. Pasha and Sharma said, we need to look at pharmaceutical care, not just getting medicine to patients. It's not enough. Do we have any questions from the floor? We need a microphone over here, please, and then we've got one over there as well. I think we have still got 3 or 4 minutes.
1, 2. Hi.
Can you just say who you are and who your question is for?
My name is Ali. I'm from Vitake Pharmacy, Western Cape. It's a question for the entire panel, I think, and it's about NHI. Two of the, I think, critical issues or criticisms that are raised against NHI often centers around funding and mismanagement or lack of management of infrastructure, things like that. And the question I've got is, particularly in view of the fact that ICPA has got such wide support for NHI, have we ever considered being part of a proper pilot project, or even perhaps spearheading a pilot project?
Who's going to answer that? Sham?
What was the last thing? Be qualified?
Are we part of a pilot?
What I was saying is that because we support NHI and because there's this criticism against management or infrastructure and funding and things like that, have we ever considered being part of a pilot? I know there have been pilots run, and the word is that the pilots haven't worked or that they've failed. But because we've got pharmacies all over the country, because we've got relationships with doctors and other practitioners, have we ever considered spearheading a proper pilot? Because, the thing is that I think often we wait in government to do things, but perhaps we can be proactive and do something like that ourselves and show whether it can actually work or not.
Thank you, Ali.
Right. So there's already a few pilots that we are running. So in the Western Cape, you'll know that we are part of the private-public partnership where we are dispensing on behalf of the state all of their oral contraceptives, their vaccines, and the immunization program. So what has happened there is the state has provided the medicines, community pharmacy, together with the state, so there's reporting, etc., the whole structure in place for that, provides the service, and the patient actually pays a fee for that service. I'm not sure what the actual numbers are. I think it's around 40 Rand for oral contraception and 75 Rand for the immunization. Is that correct? So some of our pharmacies, there one particular pharmacy does around 2,000 of these per month. So you multiply those numbers, that's new money that has come into that pharmacy. So the pilot project exists. It is now being expanded because the Western Cape is transferring some of their skills to the Eastern Cape. That project is now being moved to the Eastern Cape. So some of the pharmacies in the Eastern Cape will get access to that program. We've attempted to do it in other provinces, but the provinces have not come to the party yet. But we have put it onto the table of the previous minister and the Department of Health. The second would probably be the tiny little pilots that we're running with the NGOs. So in the Pietermaritzburg area, we've allocated a few pharmacies to do a pilot project with NGOs where the medicines, together with blood results, together with managing ARV patients, are done at pharmacy level. The NHLS, the laboratory services of government, are involved with it. They pick up the bloods from the pharmacy. That takes place with one of the NGOs as a partnership in the Pietermaritzburg area. And we've been involved with that for the last 1.5 to 2 years. Jackie, I can't think of any other pilots.
Well, I think what we're doing is we're busy engaging with the Department of Health, because PIMART, pharmacist-initiated management of ART, pharmacists prescribing PrEP, PEP, and ART, first-line ART. For us, this is extending our hand to assist the government in the high-burden districts. And the high-burden districts are not just in the rural areas, they are actually in the big city centers. And that's where we need the extra. The clinics in the CBD of Johannesburg cannot cope, and they need to actually test and treat about another 200,000 patients just in Johannesburg. We've got, in Gauteng, we've got nearly 300 ICPA members. Instantly, we bring on 300 PHCs. If you guys come and have the free training and allow us to give you Section 22A 15 permits to do this. So the pilots are already happening. We are extending them, expanding them, and that's why we say nothing about us without us. If we're discussing medicines, ICPA is there. We are sitting with the minister. We're engaging with Pharmacy Council. We're talking to IQVIA. Wherever they're talking about medicines, you'll find one of us there. Ask the students. There's a lot of students here today from TUT, SMU, and all over the place. We're engaging with our young students, and what a fiery bunch they are. I think they ran out to go and grab the minister now, so I feel sorry for the minister. He might miss his flight. Anyway, guys, I think we are running short of time, so please, very short question. And guys, quick answer. I'm going to have Gary, and I think there was Sadiq, and then Mogolokolo, I'm not sure if there was a question from the WhatsApp group. Gary, short, please, or I will cut you off. It's not working?
I'm absolutely thrilled that Seamus got on his barrier to change. Point number one, dispensing doctors. Now, that's not an easy task because, I mean, you have to change legislation, it has to go to Parliament. If you could just shortly tell us what you intend to do with that.
I'm not sure that I mentioned the dispensing doctors.
No.
Did I? Ownership. Oh, okay.
Okay.
So that's not related to the doctor. No problem. So in terms of the ownership, what we've done is a few things. Am I allowed to mention the case? So currently, in November this year, we have a High Court application that has gone through. It's actually against, unfortunately, the minister is will be one of the respondents on this, together with one of the big corporates. We think that they've contravened some of the regulation in terms of vertical integration and ownership. And that was our first point of target. And we're hoping if we can get that into court and get an interpretation of that, it opens up the issue around ownership. The second project that we're busy with at the moment is related to putting in some documentation into the Portfolio Committee on Health in Parliament. So that documentation is Mehboob. Mehboob is responsible, went to a meeting already. That document is going to be put together, and we're going to be presenting to the Portfolio Committee on Parliament in terms of looking at what, as I said in my speech, what was the initial intention of the Act? Has that intention been achieved? And if it's not, should we actually go back and reverse it? Because when the decision was made to open up ownership, we were asked about it, there's been some comments, and it opened. So it could easily be reversed. And it's not a unique situation. Other countries have done it. Hungary and a few other countries have actually gone in a process and reversed it. Whether it's possible, whether it's not, we're going to be continuing to attempt to do that.
Thanks, Sean. Okay, I am only going to take one more because I don't want to run over time. Are you okay, Sadiq? Have you got a WhatsApp question there, Makgologolo? Yes.
Okay, you're going to answer. So there's a question here that came through WhatsApp, and I'm going to try and summarize it because it's quite long. It says the current public health offering is currently failing the general public in a number of areas. How would the NHI be different? The private health sector, like community pharmacy, is stepping up and assisting a lot of those patients in need of basic health care. So the bottom line is the first part of it. How would the NHI be different since the current public?
The minister
Okay.
should have answered
So obviously
that.
that's a question for the minister, but I'm going to attempt to answer it from the fact that we're becoming supporters of NHI. So my view is that we currently spend 8.5% of our GDP on healthcare, and if you just look at worldwide, it's at the upper limit of what the spend should be in any country. Secondly, the way we spend our money, and we had extensive discussion yesterday at the dinner table in our meeting around how the system currently works, in that with a simple cold or a flu that your child has, you get an appointment with a pediatrician. It takes 3 months to get an orthopedic or a gynae appointment for a simple process that can happen in a community via a doctor or somebody trained to do it more appropriately. So I think our system is broken. NHI will force us to go back and relook at our systems. So the first thing is a system change. Secondly, I think the department will have an imperative to go and fix what's broken in what they're delivering at the moment, at a clinic level, at a hospital level. And you see that taking place with the visibility of medicines. My daughter is doing a voluntary program in an internship here in a little clinic in KZN. And she said something around, we couldn't find some ARVs and they didn't deliver. And I called the municipal manager. They went onto the system, and within 2 hours, they had a team out at that clinic to sort the problem out. So I think there's a lot of initiative that government has put in towards NHI. And I think the blurring of the lines is that what we're seeing is what's in the media. What we're not seeing is what's happening on the ground. And I think if you start to talk to patients, we've had patients who says, the CCMDD thing works for us because we're getting our medicines. We don't have to sit in queues for a long time. That's a simple concept. We're critical of it because we think more should be done for that patient. There is no way you should hand a parcel over to a patient. It's just disgusting for me as a pharmacist. But from the patient point of view, it's working. So I think a lot of change will happen for NHI, and I think we're going to get there. It's not going to be an easy process, it's a slow process, but I do believe firmly that we will get there.
1 minute, Mr. President.
No, half a minute. I just wanted to say that, yes, the public health system currently is in its worst state that it can ever be. But also lessons learned from the whole world is that there is no country in the world that has ever waited for a perfect health care system to be at a particular stage before they launched their universal health coverage. So we have to start, because if you do not start and try to wait for so-called perfect healthcare system of the delivery of healthcare system, we will actually never start. So if you start and you re-engineer your thinking around the delivery, because that's what needs to happen. The delivery of healthcare cannot be the same.
Yeah.
Re-engineering is what we need,
Yeah.
and the opportunity comes through the NHI.
Okay. All right. Before I say thank you to everybody and before everybody stands up, just quickly, in your pouch, there is a treasure hunt card. Please, guys, go out there, go to the stands, get your sticker or signature, because there are prizes. It is a treasure hunt. Guys, please support our exhibitors. They have really pulled out the stops. There's some fantastic stands out there. Please be back on time. We'll start with or without you. But before you go, please, can we give a really upstanding thank you to Michelle, Mogologolo, and Sham.